What a wonderful turnout. Good evening. I'm so thrilled to see so many of you here tonight. I'm Gina Vild. I'm the Associate Dean for Communications and External Relations at Harvard Medical School, and welcome to our second mini-med school, our second long-with seminar of 2019. Tonight, we're all here to learn about depression and how this complex condition can be decoded. So to all of us here on the Longwood campus and to those watching from around the world, welcome. We had many thousands watching from 20 countries around the world 2 weeks ago for our first Longwood seminar, and I'd like to welcome all of you who may be joining us again tonight. When we ask our past attendees for recommendations on topics, what they tell us is that mental health is very high on the list. So we were really happy to be able to respond to your request to offer this topic this year. Harvard Medical School has groundbreaking research underway, and tonight we're pleased to bring to you two of our expert faculty members who will share their knowledge with you. When you checked in this evening, you may have picked up a list of local mental health resources. We urge you to share this with family and friends if you think it will be helpful. To learn more about this topic, visit the Harvard Health Publishing website. And you'll see on the screen, the URL is www.health.harvard.edu. And here you'll find special health reports, newsletters, e-learning opportunities, and blogs on mental health and depression. And you'll also find a host of other science and health-related topics. In particular, Harvard Health Publishing also offers a special health report on understanding depression. And I'm happy to tell you that those who are here tonight and those, if you're watching from the live stream, may order the guide at a discounted price by using the code HMSLS within the next 30 days. And now please join us. I hope you'll join us for the next two Longwood seminars. Next Wednesday, April 17th, we'll have a panel of experts on artificial intelligence and healthcare. And on Tuesday, April 30th, we'll conclude with the mini-med school on why sleep matters. And if you are planning to attend, I urge you to arrive early, because whenever we offer a program on sleep, it's always well attended. So on the screen, you'll see information related to how you can obtain certificates of completion if you attend 3 or more of our seminars, and if you're a teacher and would like to receive professional development points. Our speakers will be taking questions at the end of their talk. So you have, if you're in the audience, a little card. We will be collecting those, and our speakers will try to get to as many of those as possible. If you're watching through the live stream, please write your question in the comment box on YouTube and Facebook. And when you do, please tell us where you're from, where you're writing from, because it's really nice for our audience to know. Now I ask you to silence all your electronic devices, but do not turn them off, because we'd really like you to join our conversation on Twitter by using the hashtag HMSMinimed. Did you know that 1 in 10 suffer from depression in the United States? And the World Health Organization reports that worldwide 30 million people of all ages suffer from depression. Sobering statistics. When we were thinking about tonight's program, we were really in a quandary because there were so many aspects to it, and we wanted to narrow it down to a focus that was specific enough where we could really be in depth. And because we know it strikes people of all ages, and particularly the elderly, it has a wide range of causes and symptoms. It can be diagnosed as temporary, minor, seasonal. It can be classified as a major mental health disorder as well. And there are a host of treatment options. So when we thought about what we wanted to talk to you about tonight, and we consulted our experts, we decided to focus on how depression affects men and women differently, from its causes to its symptoms and its treatments. And now I'm pleased to introduce our speakers. Dr. Jacqueline Olds is a part-time associate professor of psychiatry at Harvard Medical School and a consultant in psychiatry at both Massachusetts General Hospital and McLean Hospital. She's going to talk to us about women and depression and why females are more frequently affected than our men, which is something I did not know. But first, we'll hear about how depression can impact men. Michael Craig Miller is a part-time assistant professor of psychiatry at Harvard Medical School. He serves as the senior editor for mental health at Harvard Health Publishing and is at Beth Israel Deaconess Medical Center. So please give a warm welcome to our guest faculty.
Well, thank you everybody for coming out this evening. I feel like we're well placed before the talk on intelligence and the talk on sleep, because sleep, as you know, when you don't sleep, that can be a trigger for depression, and intelligence turns out to be pretty important too for our happiness and making wise choices. So I'm going to run through first some general principles about depression, and then I'll talk a little bit about men before handing it off to Jackie. So this is my attempt to draw an elephant. People may remember the story of the people with impaired sight who come up on this creature, and they touch different parts of it. One person touches the side and thinks it's a wall. The next person goes up to the tusk in the front and thinks it's a spear. The person comes to the trunk and says it's a snake. Another person feels the enormous leg of the elephant and thinks that this must be a tree. Another sitting on top of this beast feels the ear, thinks it's a fan, and then there's somebody at the tail who thinks it's a rope. I choose this because this is a little bit the problem with depression. We have many, many ways of understanding what the sources of depression are. We may become depressed if we experience stress in our lives. We may have a problem with our genetic makeup that causes our temperament to lead us to be more likely to be depressed. We may have suffered a loss early in life or more recently, and that can make us unhappy. Medical problems can cause depression. Early experiences can make us vulnerable to depression. And of course, the relationships that we swim in our lives can make the quality of our life better or worse. But that's not all. We, of course, everything runs through the brain. There is an argument going back at least 400 or 500 years to Descartes, who, with the argument about the mind and the spirit, the body and the spirit being separate. These arguments are interesting. The nature-nurture argument. Am I suffering because I have something wrong with my biology? Am I suffering because of something in my life experience? But the reality is it all runs through the brain. The brain is the organ with which we relate to the world. It used to be that people would say, oh, you're depressed, you have a chemical imbalance. That is probably not a great metaphor. It's one that's bothered me for a long time. But there are chemical transmitters in the brain that help nerve cells, that are really the device that allow nerve cells to talk to one another. If you have a medical problem, you're taking medications, that can be a cause of depressed symptoms. We now know that diet and exercise are very important in terms of how we feel day to day, week to week. Anybody here have a problem with seasonal depression in the wintertime? We're now in the spring, so we're getting into longer days. Many people feel worse when the days are shorter and there's less light available. We also know that as we go through life, we face different challenges. You leave college, you have to find a job, you have to figure out what you're going to do with your life. You're in midlife, you may have stress in a relationship or a job. In later life, you confront inevitable losses and the unfortunate fact we all have to face, which is we have a limited term on this planet. Now, I don't know if anybody's heard this term, but I came across it recently. It's something called a wicked problem. This is an idea that came out in a paper in 1973. These are a couple of researchers who were talking about the problems of planning in any kind of large context. And it's been picked up recently in really over the last several years in a variety of contexts. A wicked problem is a particularly difficult problem to solve. Now, difficult is probably the wrong word, because there are many difficult problems that are not wicked. Now, it's difficult to go to the moon, but it's a problem that can be solved and was solved. It was difficult. It took a lot of energy and a lot of effort. But we conquered that problem many, many years ago. There are many problems, though, that we face, like poverty and questions about economics, and I would argue depression, that don't fit in this model. And it's one of the reasons that depression is so hard to talk about. And as Gina said, this trouble we had in sort of figuring out what the focus should be this evening. So a wicked problem is one that does not have a defined formulation. It doesn't have what they call a stopping rule. In other words, once you get to the moon, you've solved the problem. You know you've solved the problem. With depression, what is our goal? We can't eliminate sadness. We can't eliminate discomfort. We can't eliminate pain. It's part of life. So how do we separate what we think of as normal ups and downs, in quotes, from something that becomes the subject of treatment and study? It's hard to test whether you've solved the problem. What is the goal if you're feeling down? You know, many people ask the question, Dr. Miller, how do I know whether I've got, quote unquote, clinical depression? And I never know how to answer that question because it's a very hard, I mean, you can look at the list of symptoms and I'll show them to you in a minute, but it's a very, very difficult question to answer because it's ultimately subjective. The answer I often give is if you're asking the question, you might want to go talk to somebody and discuss it to see if, in fact, you have a problem that you could get some help with. There's another issue that comes up, and for many people who are here, I'm sure, are interested in the subject, and I'm sure you do reading, you know, all the disagreements. In the last month alone, there was a long article in the New Yorker, there was an article in the New York Times, there was an article in the Atlantic, all with this question about are we causing problems by prescribing too many antidepressants? And when people decide they don't necessarily want to take the antidepressants anymore, and they try to stop them, and they get into problems with symptoms that emerge when you stop a drug, what do we do about that? And you know, you will find websites that will say you should never ever take a psychiatric drug. There are organizations like, you know, anti-psychiatry organizations, fine, who say the drugs are just poison, and you should really solve your problems in other ways. And then there are problems that really are based so deeply in the biology that taking a medication can be helpful. And you get arguments from experts on either side, and the experts get very, very good at arguing their case. And all of you are sitting out there not knowing who to believe. That is, in a way, a definition of a wicked problem. So let's talk for a moment about these categories of depression. I want to, before I show you the list, you've, I'm sure, heard some of these words. I would recommend for most people who are trying to get help with low mood or what they think of as depression to not worry too much about the diagnoses, because again, these are not diagnoses like pneumonia, you know, pneumococcal pneumonia or asthma or diabetes, where you can identify where the pathology is, where the problem is in the body, and provide a treatment for it. These are all what I call syndrome diagnoses. That way, they're collections of symptoms. We use them in psychiatry because it's helpful to study treatments by grouping people together who roughly have the same symptoms. But as with the elephant, two people with the same set of symptoms may have very different biology, they may have very different backgrounds, many different roads to getting to what look like the same thing. So what it looks like on the surface often doesn't tell us exactly what the underlying problem is. The big diagnosis in this category is what we call major depression. This is the full-blown depression with all of the list of symptoms, which we'll see in a minute. It's very long-lasting. It doesn't have to be long-lasting, but it's a very deep, distinct change in mood with a variety of symptoms. And as Gina pointed out, it's highly prevalent. 17 plus million people in the United States alone have met the criteria for this diagnosis. Something that used to be called dysthymia, now called persistent depressive disorder, what some people call minor depression, although the criteria and the way people define it, they'll argue about. But I think of this simply as the Charlie Brown form of depression. I'm fond of this diagnosis. My sister-in-law played Lucy on Broadway in What You're a Good Man, Charlie Brown. And so Charlie says to Lucy, "Oh, Lucy, I'm so depressed." You know, and Charlie is one of these guys who is always at least a little bit low. And this diagnosis, this type of depression, is a kind of thing where I've always felt, you know, it's just so normal to me to always feel a little sad, a little down, a little joyless. So that's persistent depressive disorder. Oop. Bipolar depression. So this is the depression that emerges in the context of bipolar disorder. Bipolar disorder is defined as a cycling mood disorder where people may have periods, up periods that are called mania, or sometimes, not if it's not fully mania, hypomania, and periods of depression, which is thought to have a different biological basis. Postpartum depression is a well-known phenomenon. It's distinctly different from, it's quite common for women after giving birth to have periods of mood that varies or to feel low, something that's called baby blues. But a smaller percentage of people have a depression that is more like major depression. And psychotic depression, again, all this means is a kind of depression that is accompanied by symptoms that involve changes in thinking, hallucinations, delusions, ideas that are fixed ideas that don't meet with reality. So these are the basic symptoms of depression. People think of the mood of depression as being sadness or low mood, but sometimes it feels like emptiness or irritable mood. And so many people with, and I'll tell you a story when we talk about men in depression. This is particularly common with men who may not describe feeling sad or down, but they'll be irritable and feel empty. Hopeless, pessimistic, feeling guilty, worthless, or helpless. This next one, loss of interest or pleasure in usually pleasurable activity, something you may have heard the word anhedonia. Hedonism is taking pleasure. A hedonist is somebody who just loves having fun all the time and goes after it. Anhedonia is the inability to take pleasure in things that are normally pleasurable. I go skiing, I go to the movies, I am out with friends, and everything just feels flat. I take no joy from anything. Low energy, feeling tired, poor concentration, indecisiveness, changes in appetite. It can be either gaining weight or losing weight. And sometimes it comes out in physical ways with aches and pains. Now, the thing we worry about most related to mood problems is the risk of suicide. Now, unfortunately, the rate of suicide has gone up. There are more suicides over the last 10 or 20 years. There was a long period where there was a falling off in the number of suicides in the country, but it seems to have gone up in the last 10 to 20 years. But as a phenomenon, it's fairly rare, which is the good news. Which makes it, but the bad news, again, because it's rare, it becomes hard to predict. It's hard, there are many people when they feel bad, they feel empty, may feel like taking their own life, they may think about it, but fortunately, very few people act on it. But we're always concerned with how do we help the people, how do we identify the people who are really intending to, and unfortunately, since we can't read minds, we really depend on people telling us, which they sometimes don't do. So it's a very knotty problem. But in general, risk goes up when the depression is severe, when there's a lot of anxiety along with the depression, and when there's distorted thinking, with something we call psychosis. It may be a higher risk when there's been a recent loss. A spouse dies, particularly if it's a long marriage, loss of employment. Loss of social support is a risk factor. A personal crisis. Now, a lot of these things group together, and that's when it becomes particularly a time to be concerned. If somebody goes through an experience where they suffer a tremendous loss, a spouse dies, they lose a job, but it's in circumstances that cause them to be more isolated, maybe cause them to feel humiliated, where there's a loss of self-esteem. It can be a steamroller effect where a person really feels like there's no option. Substance use, particularly alcohol, is a huge part. Something like 2/3 of all suicides involve the presence of alcohol or some other substance. A person who's made prior attempts is at more risk. And now here are the two big ones. A family history of suicide. If you hear somebody's parent committed suicide and they're feeling suicidal, that's a very that's a time to pay very close attention. And fortunately, we don't have this problem as much in Massachusetts as we do in other parts of the country where there are more firearms. I was at a dinner the other night with a bunch of very progressive, let's say, very to the left of center people. I'm not not making any judgments one way or the other. And a bunch of the people in the room said, there are more guns. More people who own guns than you think. And in this group of progressives, something like 40%, there were 12 people there, so there were like two or three households that owned guns. And I was a little surprised. Personally, I've never held a gun or had much of an interest, but I was working with some people from Texas on a case where I was consulting, and all the lawyers owned guns. And a friend of mine who was giving a talk at the University of Texas said, "Who owns a gun?" And about half the class just showed their firearms to the professor. So even in Massachusetts, where fortunately, again, we have one of the lower suicide rates in the country, you might guess that in states where gun laws are more lax and where there's less access to care, places like Wyoming and Idaho and Alaska, the suicide rates are much higher. All right, let's talk about treatment. So in your reading of the popular press, much of which is very good and very interesting, and I recommend you look for these articles in the New Yorker and the Atlantic because they make some good points. You'll come away from reading these articles, and the problem with most of the articles is there's usually some kind of bias on the part of the writer, which gets back to this issue of the wicked problem, because it's very difficult to be objective about these things. Often because, there's a website that we collaborate with called Help Guide, which is very, very good, worth taking a look at, very practical advice. And you can read this story. This is a couple who decided to start this website because their daughter had terrible depression, ended up committing suicide had a lot of treatment with medication, and they felt very strongly that she didn't get the care she needed because all she got was the medication, and she didn't get a lot of the other things that she needed. And so there's a lot of very useful advice. So I understand that perspective. But I also understand the perspective of somebody who suffers, gets a lot of psychotherapy, has a lot of love and support in their life, and yet they have this depressed mood that's very dense, and they take a medication and they feel tremendous relief. The bottom line is that this is not and again, goes back to the wicked problem. This is not a one-size-fits-all problem. If you have a friend who you talk to a friend, you say, I'm feeling down, as people do, and I'm thinking about consulting a psychiatrist or my doctor and getting an antidepressant. And the friend says, oh, I have a cousin who takes Wellbutrin, and it really just changed her life. You should try that. Well, that's no guide at all. Now, if your mother or father took Wellbutrin and it was helpful, that might be a guide because a person who shares your genetics responded to it. But in most cases, it's completely trial and error, which is problematic because people come in, I don't want to be a guinea pig, but in fact, the reality is that the only way to find out what works is to try things. And so, and this becomes a problem with researching medications, and the reason why the data is so bad on medications. And usually take 100 people and give them an antidepressant. If you compare them to people who get a placebo, 40% will get better with the placebo. 60 to 70% will get better with the antidepressant. And then there's a 20, 30% who don't get better with either. But if you use a different antidepressant and you give it to the same 100 people, you may hit the same data, but different people will respond. So people's genetics is different, their circumstances are different, their tolerance, their side effects are different. So the reason I put a 1+ to 3+ in this category is that medications sometimes are tremendously helpful, sometimes they're a little helpful. Psychotherapy is the other big tool that we have. There are a variety of types of psychotherapy. And it's also effective. Cognitive behavioral therapy, which you may have heard of, is something that's very well studied. There's a lot of evidence that it is also very effective as medication in the same data range. Brain stimulation. That sounds like fun. I do it, reading a book. There's a lot of forms of brain stimulation that we all enjoy. Netflix. But what we're talking about is the range of treatments that are really historic. The most effective treatment for certain kinds of depression is electroconvulsive therapy, the treatment made famous in One Flew Over the Cuckoo's Nest. It is extraordinarily effective in selective groups of people. It's life-saving. When I was a resident, as somebody who came in as an English major who really wanted to talk to people, I was astounded at how people could be deeply depressed one day, and then after a few treatments, they get tremendous relief. And so there's a lot of fear about this treatment, but the way it's done now in a modern context, it's very helpful. But there are now newer forms of brain stimulation, which I'll tell you about. And then finally, on the positive side, are lifestyle changes. And I am surprised as a psychiatrist how much time I spend talking to my patients about healthy living. I mean, they think they're supposed to get that from their primary care doctor once a year. But I'm kind of a pain about this stuff, and so I beat this drum. On the negative side, or the plus-minus side to positive side, there are things like herbal treatments, omega-3s. You read about them, you go into Whole Foods or your natural food store, and people will tout them. Again, nothing wrong with trying these things, but and some people will swear by them, but the evidence is equivocal. Light boxes are helpful for people who have seasonal mood disorders, and they're worth investing in. Again, you can't. There are very few treatments that change everything and turn complete darkness into complete light. But again, with a combination of things, you can see improvements. I've sort of covered a lot of this stuff. The basic classes of medications are listed here, the SSRIs that you know about, newer antidepressants. But then there are these other adjunctive treatments, mood stabilizers, antipsychotics you'll read about, anti-anxiety medicines, depending on a person's symptoms, are often brought in to augment. And these are the brand names for those of you who... and this is the list of the different kinds of psychotherapy. Cognitive behavioral therapy is focused on thoughts. Interpersonal psychotherapy focused a lot on structures in relationships. Psychodynamic psychotherapy, which derives from psychoanalysis, the Freudian therapy, is much more, you'll find the stereotype is that the person just sits there and doesn't say anything. People are much more talkative now. Behavioral activation therapy is something you can read about. I'm running a little short on time, so I'm going to skip over that. And being creative. Medication versus psychotherapy. I think I've sort of implied that medication can sometimes be simpler. You go, you get a prescription, it's a little easier, but it's harder in the sense that there are side effects to deal with, and it is a trial and error process. Psychotherapy requires more of a commitment, but may be more lasting. The hard part here is that sometimes it's hard to find the right person, and your insurance company may not pay for it. And there's now strong evidence, very strong evidence, that the combination really is the best treatment for depression. There's strong evidence that exercise helps. With very serious depression, you can't cure depression with exercise. But the more active you are, the better. The more you adhere to a healthy diet, the better you'll feel. These are all contributors. I am a big fan of mindfulness meditation. I meditate. I find that many of the things that you might find in Buddhist psychology are very powerful, and I would argue it's the oldest form of psychology on the planet, dating back 2,500 years in terms of understanding suffering, the sources of suffering. Yoga as a physical sort of combines the meditative effects. Staying related, being creative, these are the kinds of things that I recommend for everybody. And if you build these things into your life, you give yourself a better shot. I'm going to skip over this. I've already mentioned these different herbals. There's a little bit of evidence for St. John's wort, a little bit of evidence for SAMe. Kava and valerian are things taken for anxiety. There is not, everybody gets things with acai now. There's not very strong evidence that it's helpful. If you find it helpful, if people find it helpful, I wouldn't argue with them, but okay. I'm going to now skip quickly to the story of men, and we can talk more about this. People know who Terry Bradshaw is? For those who are not football addicted, I've actually been withdrawing from football for a variety of reasons. I don't like what it does to the brain. But Terry Bradshaw was the GOAT before Tom Brady was. He was, the greatest of all time. He was the first quarterback to get 3 Super Bowl rings. He was the first quarterback to get 4 Super Bowl rings. And he then went on TV and was a commentator. Got cars, he got land, he got horses. I did not put women on this list, but I think there were a few wives. The problem is, and I got to talk to him a few years for an article I was writing for Newsweek magazine. Unfortunately, he was filled with dread. At the end of he would win the Super Bowl, and the next day he would say, now I got to get back on the horse and do it again. He felt flat, no joy, no pleasure. He said, I didn't remotely consider that I might be depressed. I got to talk to him as part of a campaign that a drug company was doing where he was taking their antidepressant, and he was the poster boy for that for a while. Depression in men. The rates are lower, but that may be for a variety of reasons. Men are less likely to acknowledge depression. They are less likely to acknowledge depression to themselves, as I mentioned before. They have less depression. They make fewer suicide attempts, but they actually commit suicide at 4 times the rate that women do. 80% of suicides are men. They're more likely to be irritable and without pleasure rather than sad. And we may miss their diagnoses because they are using substances, they are novelty seeking, they're reckless, they get into violent trouble. This is a shorter URL that you can use to get to and the capitalization is important for getting to this special health report. The punchline on the Terry Bradshaw story is that he told me about, he got his 3rd divorce. He was unhappy. He started taking the antidepressant, and he felt tremendous relief. So I asked him, so, you had the Super Bowl, you're on TV. What do you like to do now? He says, eat peanuts, which I thought was terrific because, the reality is that we don't solve depression by winning a Super Bowl. I mean, it's nice if that's what your goal is, but very few people get to do that. And as you hear, somebody who did do that 4 times, it was not a relief for his depression. But really, mood problems are experienced in a kind of day-to-day, moment-to-moment way. And if you can find joy in eating peanuts and sitting with your family and watching Netflix, this is really, to my mind, what you're looking for. So why don't I think I'm over time, so I'll hand it off to Jackie Olds, who will talk to you about women.
I think this is a topic that I have actually wanted to talk about for a very long time, even though most of the talks I have been giving recently are about loneliness, since that's something I've written about at length. But loneliness and depression are closely linked. It's a rare person who experiences depression who doesn't feel terribly lonely, because depression makes you feel so apart from everyone else and as if your relationships are more empty. So I think some of my work on loneliness might be relevant today. First, let me tell you the story of one of my patients. She came to see me, I forget the slides sometimes. She came to see me many years ago because her life was plagued with fears that she would die of a dread disease or that some catastrophe would happen to her and she wouldn't be able to take care of her family. And it's true that she had a tendency to feel lonely. And as she told me about her life history, I came to understand it a little bit better. She felt too closely held by her immigrant Turkish parents, and they never really wanted her to leave home at all. They didn't even want her when she was a kid to play with other kids because the world seemed filled with dangers to them. As she grew up and went to high school and then college, she fell in love and got engaged to a boyfriend, and even then, her parents really didn't want her to move away from home. But finally, at about age 27, she had the chutzpah to move into an apartment of her own, And after a while, she moved in with her boyfriend and they got married. But her life continued to be plagued with fears about terrible catastrophes and sicknesses and possible cancer. And really, she came to me to see whether I could help her with this. And I did prescribe antidepressants, and we did work in psychotherapy, but it didn't really relent completely. She continued having it year after year. And then one year I stumbled on the possibility that her fears were somewhat determined by superstition, because she'd had such a pleasant and prosperous life compared to the one her parents had had. And she felt guilty. She felt that it was such a wonderful life that some catastrophe was bound to happen to her. And we both thought about the evil eye and how in Europe and, in the old country, women had very little control over how their loved ones were doing. So they were always trying to appease the evil eye. And this is most demonstrable when older women would see a new baby and they would say, "You have a very ugly baby." And you always said that because you didn't want the evil eye to get on your case because you thought everything was going to go hunky-dory. So you would always be preparing for the worst so that the evil eye wouldn't get you. And this made me wonder about American women and the way in which we might be superstitious as well. Now, just to go back for a moment to some of the things Michael went over, these are the classic symptoms of depression that both men and women experience. And he showed you the same list. But overall, we could say that men are more likely culturally to conceal their sadness and become irritable or angry and use substances, while women have permission to talk about their feelings and often are able to ask for treatment. And so women's societal permission to ask for help and to talk about their feelings really works to their advantage when it comes to getting treatment. Here are some of the symptoms that men are more likely to show: that they have a loss of interest in some of the things they used to like, sleep problems, physical problems. These are all things Michael just showed you a similar slide of. And sometimes what they say about men is that they have so-called masked depression, M-A-S-K-E-D, that you can't really see it as depression, but you see all these symptoms that are different from how the man used to be. And it turns out that that is a kind of mask that a man puts over his depression because he feels it's weak and effeminate to admit to depression. Now, on the other hand, these are signs that women show more frequently when they're depressed. And they actually correlate a little bit with seasonal depression because, overeating, excessive sleeping, ruminating and dwelling on things, negative self-talk, a lot of that goes along with seasonal depression, which I sometimes equate to a kind of wish to hibernate until the light comes back. But the interesting question that many people have wondered about, and I'm amongst them, is why do so many more women seem to experience depression than men? Is it just that men are loath to admit it? Or is it that women, in fact, in their biology, are just a little bit more likely to get depressed and to be able to say so? So here we see some of the statistics on women in America. And what you should remember is that 1/8 of women will develop clinical depression over their lifetime, so that's a huge percentage. It occurs most often during the childbearing years, and more than half of those women will not seek treatment at all. So even though they have all that societal permission, they don't necessarily come to seek treatment. We'll talk more about that. Now, many people have speculated that depression happens more often in women for biological reasons because of all their hormonal fluctuations. And we know that depression happens 1.7 times more often in women throughout the world, whether we're talking about first world countries or third world countries. And the prevalence seems to correlate with times of great hormonal change. It increases around puberty, menstruation, pregnancy, and menopause. So certainly there's something biological about it, but there may be more than just the biology. And so there are lots of cultural generalizations we can wonder about too. And as I say in this slide, we can speculate about these because nobody knows for sure why there is such a greater percentage of depression in women than men. Just to talk about a few cultural examples at the beginning, and then I'll talk a little bit more about my experience in my practice. As you can see from this slide, women are at increased risk for depression if work interferes with family life too much. But on the opposite side, men are at increased risk if family life gets too much in the way of work life. And in fact, in this Canadian study, which was a rather large study, women had an increased risk of depression if they worked full-time, because that often did get in the way of their family life. And so most of the research implies that if women can have a flexible part-time work schedule that allows for family needs, then they're likely to find some contentment. And later I'll talk about how the more hats, the more different roles a woman has, often the more contented she is. But it's also true that there was a very famous article in 2012 by Anne-Marie Slaughter called "Why Women Can't Have It All." And it was a really important article because what it said is no matter which pathway you take nowadays as a woman, you can decide that you're going to be a full-time mother, you can decide you're going to be a full-time career person, you can decide you're going to try to do both. Whatever pathway you pick, you're always haunted by guilt and doubts about whether it was the right one. Even if you're living solo and you decide not to have children, or you don't freeze your eggs, or you decide that you're going to go without children, women who might be content in a different era are always wondering, should I have done it that way? Should I have done it this way? So it does seem that all those choices for women have not necessarily led to greater contentment. We see that in response to stress, this is another cultural difference, that women are more likely to essentially compare notes with other women when they're feeling stressed out. And what it means is that they're in a position where they don't feel they have friends or they don't have anybody to compare notes with, they often are overwhelmed. Interestingly, nowadays I find that women who go to their friends and say, I'm horribly depressed and feeling overwhelmed and I just don't know what to do, I'm worried about my children and I'm worried about my marriage, the friend will say, well, I think it's time to seek help. And what they mean by that is, maybe you should see a therapist, which is fine. Speaking as a therapist, I'm glad they're in favor of it. But I'm a little bit worried that friendship used to be, the currency of friendship used to be talking about the troubles you had with a friend and comparing notes so that you could find out, you could regain your perspective. And nowadays, if you go see a therapist, you never actually get that perspective unless you happen to have a therapist like Michael or me who will say, well, everybody feels that way sometimes. But in fact, it's a little bit worrisome that friends are so worried about imposing on other friends nowadays and that they feel therapy is the right place to go. Now, even though women have often some different issues than men in their depression, overall, we would have to say that the specific treatments for women are underdeveloped. We don't have a completely different pathway for men and for women in their depression. We do now there's certainly medications that treat menstrual dysphoric disorder, and there are hormones you can take after or during perimenopause to try to make your quality of life better. And just recently, there's a new medicine called brexanolone, or its brand name is Zulresso, for postpartum depression. So that's hot off the press. We do find that women tend to prefer working with women therapists often because they can do a little more of that comparing notes and they feel they will be understood when they talk about their issues. But it's also true that men sometimes have a preference for women therapists as well. This is not just meant to be an advertisement for women therapists. It's more that we should recognize that what girls do in their growing up is talk about everybody's psychological makeup. Figuring out what makes each other tick, and what makes your parents tick, and what makes your brothers tick, and your sisters. That is what we do. And so it means that everybody has a kind of psychological and psychiatric residency as they grow up. And that does help in in allowing us to talk about psychological issues as if we always have, because we have. It is true, however, that many women and many men prefer talking to male therapists, men especially, because they feel the male will understand their issues. And some women who were best friends with their father and maybe not so close to their mother may prefer working with men as well. Now here, I'm going to talk about a number of things, other possible cultural reasons for increased depression in women. And each of these little points is going to have its own slide, so you don't have to memorize them because I'm going to go on and talk about each of them. But these are some of the things I've noticed after 40 years in practice, working with, I'd say 70% of my practice was women, young and old. So first, let's look at this changes in sense of purpose over the life cycle. You know, many girls grow up with the notion that when they find their perfect romantic partner, that will be the answer. But that is a kind of myth that leaves lots of women frustrated. What if he or she can't be found? What if he or she doesn't solve all their problems? And it's also true that women may consider having children by themselves or with a partner, and that does sharpen their life with a sense of purpose over at least 18 years and maybe longer. But it means that when they become an empty nester, there's a terrible loss, which may leave them feeling without a sense of purpose. And so they have to somehow shift gears completely, and that is a time when many women can feel depressed. They have poured their heart and soul into raising these children, and the children fledge and fly off. And that is just what they wanted, but it doesn't mean that they have an automatic sense of purpose immediately. And the women, I think the reason there's all that sociological research about women needing several roles, like several hats, is because they don't have all their eggs in the child basket, basically. They have a job which they might be able to find satisfaction from even when their children grow up. We do know, and I'll talk more about this, that unstructured time can lead to brooding and depression in almost everybody. So that's why a sense of purpose is such an important thing to find. Now this next slide it sort of goes back to my talking about superstition. And first I have to tell you an anecdote about my driving carpool for about 8 years with 2 boys and 2 girls. The boys were older, the girls were younger, and I got to hear them talking to each other about what they were about to do. So for example, if the boys were talking about a test they were about to take, they were in the same grade, the girls and the boys. The boys were 2.5 years older. So the boys would say, "Oh, are you ready for your history test? Do you think you could do it?" And the other guy would say, "I'm ready. I highlighted the whole chapter. I really have it down. Oh, you should see my chapter. It's so well highlighted." And the other boy would say, "Well, you think you've got it. I had my parents give me 3 quizzes, and I really aced them, and I think I'm going to do wonderfully." So they would psych themselves up to go take this test. And I have to admit, they did rather well on their test. But it was wonderful to hear them talking about how well they were going to do. And then I would listen to the girls talking about getting ready for a test. You know, "Are you ready for the French test?" "Oh God, am I not ready?" I had to stay up till 2 in the morning, and I still didn't know it. There's something wrong with my brain. I just can't memorize all those words. And the other girl would say, "Oh, I know just what you mean. It was awful. We are going to flunk. Will you be my friend even though I flunk?" "Yeah." "I'll be your friend." And then they would go off and take this test, and it would turn out that in general, these girls did better than the boys did. But you would never know from their talk to each other that they were going to do well at all. And so I came to believe that this was the American form of superstition, that you don't want to jinx yourself, so you prepare yourself for the worst. And it's also true that in any group of women or girls, if somebody seems to be too swell-headed or conceited, all the other girls and women put them down. Who do you think you are? Why do you think you're going to do okay on the test? Give me a break. So it is really true that there is, from 2 different directions, a kind of force on women to not allow themselves to psych themselves up. They psych themselves down. And so my question is, and I don't know the answer, this is speculation, if women are always preparing themselves for the worst, does that affect the outcome? Are they more likely to get depressed because their self-talk is so depressing? And it's depressing because they're trying not to jinx themselves. And that's not always true, but it's sometimes true. So I want you to think about that one. Then I'm going to talk a little more about these romantic notions that I alluded to. If girls are still brought up to believe that a romantic partner will solve all their problems, does this mean that they might not try to excel in their own right? And they might spend all their energy and their creativeness in trying to find the perfect partner who will then make them feel whole. And that myth, which is not as prevalent as it used to be, but it's not disappeared completely. Although my daughter tells me that Frozen is trying to work against this. That because that movie Frozen, in the end, the sister rescues Elsa, not Prince Charming. So it's very important to notice that this is the first movie where a woman rescued a woman when she was in trouble in sort of the Walt Disney firmament. But with these romantic notions, it's so much easier to criticize your partner than figure out how to succeed yourself. And at times, when a woman is feeling unhappy with how she's doing, she is quick to blame her partner rather than accepting the responsibility that things might not be going well for her own fault. And so I can't tell you how many women essentially feel that because they nurtured their husband's career, that kept them from having a career of their own. And sometimes there is some truth to that, but there's getting to be less truth to that. And so it's not necessarily a good marital policy to always blame the other person. And certainly we women have sometimes had that tendency. I often find also that the attitudes of women around men are not necessarily what you would hope. Many girls who were best friends with their fathers growing up had a kind of deferential attitude where they checked with their father and they listened to their father and they were so proud of their father but always played the deferential role. And then when they grow up and they have male mentors or male professors or male partners, they fall right into those patterns again. And the hard part is that it causes them to not trust their own judgment. And I do have a patient right now who is about to take a position. This is a woman of authority. It means that she will be the mentor instead of having the male mentor. And ever since she said yes to this job, she has felt completely sick to her stomach, filled with dread and worry that she doesn't have good judgment. And that without the imprimatur of a male mentor saying, yes, that's just what you should do, she won't be able to handle it. Then there's the overemphasis on physical appearance that women have to contend with throughout their lives. And if women are brought up to see their power as the same as their level of attractiveness, then as they grow older, they feel more and more invisible and disenfranchised. And by the way, the bread and butter of older women's conversations goes as follows. Did you see that cashier didn't even look at me? I was completely invisible. They just handed me the money and said, no problem. And I can't tell you how often older women are feeling like their oldness keeps people from really acknowledging or noticing their existence. So when women do have jobs with a sense of purpose, that is able to sometimes carry them through the fading of their level of attractiveness. And also, if they earn some money, it makes them feel like there is still some power that they have in a marriage or a family, even though they're not who they used to be at 30. This is the sociological slide that really says that when women fulfill more roles, they wear more hats, then they're more likely to be content. And we know that many children and men would like their wives to be kind of always available for rescuing them or taking care of them or being there if they have a question. And so there's always that pressure on women, even when they do have a wonderful job that gives them a sense of purpose. And so there's always the guilt to contend with, but I think the research seems to show that women who both are able, if they do decide to have families, to handle that with at least a part-time job that gives them some flexibility, they are more likely to be content. But as we talked about before, there is this problem for women who didn't work and raised their children and then find themselves with much too much time on their hands. And here's where I want to quote a fantastic author whose name is completely unpronounceable. Mihaly Csikszentmihalyi. He wrote a wonderful book that I would recommend for all of you called Flow, The Psychology of Optimal Experience. And this is an old book. He studied contentment for something like 30 years. He was a professor at the University of Chicago of psychology. And what he found is that the more flow activities, and I'm going to tell you what those are, you have each day, the more likely you are to be content. And what a flow activity is something where you enjoy doing it so much you don't notice the passage of time. You could do it for as long, you would like to not have to stop doing that activity. And you can see that you're making improvements over time. So it could be anything from collecting wildflowers to, keeping the football statistics to, doing your stamp collection. It could be anything. But the more flow activities you have, and often a job gives you some flow activities because sometimes you love solving the problems at the job, the more likely you are to be able to keep your head above water and prevent depression. And this isn't talked about enough. But in fact, almost everybody who has huge amounts of unstructured time, like when you're on vacation and you're on the beach, it turns out most people get fretful and brooding and somewhat depressed when they're lying there on the beach. You ask people, would you rather be on vacation or at your job? And most of them say, I would much rather be on vacation. But when you actually do a diary 8 times a day when they're on vacation, it turns out they're less content than when they're working, which maybe is why so many Americans leave their vacation days alone. Now, the new model of family, the sort of modern notion of family at its best, is as follows: that both women and their partners can do child rearing and have careers. Each has a kind of portfolio of flow activities. Neither partner is overvalued for one thing: physical appearance, family background, financial clout. And each person can spell the other in most activities. So, one partner can babysit for the sick child one day and the other partner can babysit for the sick child the second day. Or one person can, figure out how to change the washer in the faucet one day and the other person can maybe figure out how to change the washer in the faucet. So it's a very new and wonderful model. It's kind of aspirational because few people achieve it, but it's something to think about. Now, what about all the single women who live solo? By some measures, these women are the happiest. And often, they never have to change the washer in the faucet. They call the plumber. But oftentimes, they have superb social skills which allow them to cultivate very long-term friendships. And they arrange their social life. Even though it's hard when you're living alone to arrange a good social life, the fact is these women sometimes have incredible social skills. And they sometimes have jobs which give them a sense of calling. Calling meaning that they feel they were meant for that job, it gives them a huge sense of purpose, and their decision to remain single or childless was quite a wonderful one. But some women may feel judged by others if they decide not to have children or not to get married because they didn't have that part of their experience, and some of those women feel it wasn't a voluntary decision at all. And sometimes they worry terribly about how things will go when they're older and they need medical care or they're depressed. How will they manage without a relative to take care of them? We should remember, of all US households, 27% are one-person households, with women making up more than half of those. And that's in 2010. In 1970, it was only 18% of households were one-person households. I'm running out of time here. So, as Michael said, there are lots and lots of treatments for depression. But the reason I want us to talk about them is that many people who don't seek depression say, well, I don't want to go see a therapist who will tell me what's wrong with me. And I don't want to take meds because I'll be on them forever and they have horrible side effects. They'll make me fat. Why would I want to go on medicines? So many people too quickly leap to the conclusion that neither therapy nor medicine is for them. But the fact is there are a lot of possibilities here. You know, there are all kinds of non-medication interventions. There are all kinds of family therapy or couples interventions. There's talking therapy. There's hospitalization if necessary. There are the rest cure and forest bathing possibilities. So there really are some other things than just hearing what's wrong with you or going on a medicine you have to stay on for life. Now, I just showed this picture of young women because some of their issues are very different, and I just want to mention them for a moment. The typical young woman is wondering, will she ever get asked on anything that looks like a date? Is she feeling like all her friends are having much more fun than her because she's watched Facebook and it looks like everyone's having a better time? She's wondering if she'll ever achieve her goals, or if she should freeze her eggs if she wants children, or whether she'll ever find either Mr. or Ms. Right. Or maybe she's worrying that she hasn't done a good enough job of being a friend or a daughter, or that she hasn't eaten properly or exercised enough. These are all the issues I'm hearing from the younger age group. And they're a little bit different from the older age group. I'm almost done here, and I see my time is almost done, so that's good. I want to say that women are in a very different position than men in terms of what society gives them permission to do. Women are allowed to show feelings much more transparently than men, and they can admit to depression and not be seen as or feel like they're becoming wimpy. And then maybe their greater leeway to have and show sad feelings may cause longer lives. Because many of the diseases like high blood pressure and heart disease could come from feeling so bottled up, and that you can't show your true feelings as a man because it makes you less of a man. But then we also have to ask ourselves, does this societal permission for women to show more feelings, does it prevent the true empowerment that women would like to have in the workplace? Because so many people, if they do show feelings, say, well, she's not very professional. Did you see she was crying when she was hearing perfectly reasonable feedback? And there are all sorts of ways in which women are graded down for that societal permission to show feelings. So it's a kind of interesting quandary. As women spend more time in the workplace, will they become more bottled up and have more of a kind of blank face where they try desperately not to show their feelings? And what are the trade-offs of having society's permission to show feelings? And with that, I'll stop. Thank you so much.
Can you hear me? Is this... We have a lot of great questions here, and really all the questions that were passed in are terrific. Obviously, we're going to have till 7:30. Is that right? It was amazing and wonderful to listen to you.
And you too. Thank you.
I wanted to ask you this because this. It occurred to me when I was reading the questions, I'm sort of playing also the role of the moderator of the questions here. There were a number of people who I realized that we've been terribly heteronormative.
You mean if you're living solo or you're living with somebody
No.
of the same sex?
We have been talking about heterosexual men and women.
Not me.
Well,
I said partner.
No. But what I'm saying is that a lot of the literature that we're talking about and a lot of the experiences that we're talking about leave out the special problems that one confronts in an evolving world where homosexual, the LGBTQ community and transgender individuals face problems that don't fit into either side. And I wondered if you had any thoughts about how to talk to
Those issues.
those issues with this group?
Well, what I think is that no matter which pathway you take, and there are many more pathways than there used to be, the kind of memes of society, the things that we were talking about are there on the television, in the newspaper, in the books, and so you can't quite get away from them, even if you've chosen to try to get off the track. And so I think they're not, what we had to say was not completely irrelevant. There are so many same-sex couples in Cambridge, where I live, who have children and parenting issues. And so I don't think what we said was irrelevant, but it might not be as relevant.
Yeah, what it got me thinking about reading some of the questions was about this wicked problem. That it's also true, when you were talking about the children in the car and their approach, I mean, I was much more like the girls.
Really?
You know, worried, did I study enough, et cetera, and you know, so there's, I guess I just want to alert people that the generalizations that we're talking about here, we're stuck because we're trying to understand the phenomenon of mood changes by looking at large populations, because that's one of the ways we learn. But when it comes down to it,
There are a million exceptions.
there are a million exceptions, and in fact, everybody's an exception. And
Right.
that getting help for whatever you suffer with is always a one-to-one conversation. And actually, that is the solution to wicked problems, that not to have people arguing in big conferences, but to have a small group or two people sit in a room and discuss all the variations. And that's really what one does when one goes to seek help. You know, I mentioned before, somebody asks, wanted to know if CBT is the therapy with the best results because it's the one that's most studied. And what's the evidence for treatments that are closer to the tradition that we initially studied in psychoanalysis and psychodynamics psychotherapy. You know, this is, in Boston, you're more likely to find people who have that psychodynamic background than you will in many other places, because this is a place like here in New York and Los Angeles, certain cities that have been centers for psychoanalytic teaching. But somebody was asking about the evidence. What are your thoughts about that?
So CBT, cognitive behavioral therapy, is a kind of manualized therapy that really seems to work very well and has been studied extremely much more rigorously than many other kinds of therapy. And the studies seem to show that it's very helpful. But in real life, if a person and their therapist have a certain magic in how they can talk to each other and listen to each other, it actually doesn't matter what school of therapy they're in. It turns out that you know, the theoretical training that the therapist has is not as relevant as you might think. What really is relevant is whether they feel a certain je ne sais quoi when they sit with each other. So I think that is even more important than CBT having wonderful statistics.
And I think the evidence backs you up, because the most important factor in studying what psychotherapy is successful is if you like your therapist. It doesn't matter what the theory is. If you connect to the person, you feel the person is understanding you and relating to you. The challenge is to find somebody. You know, I mean, I think that we're old enough that we use a lot of different things. I mean, that there are a lot of, in the work that I do, I use what I learned in psychoanalysis school, but I also use CBT techniques, and I do as much teaching I can about the kinds of things that might be helpful, and so you know, in reality, you're not going to find somebody who only does
One thing.
One thing. Coffee. Here's a question.
Coffee?
Yeah, we didn't. I have nicknamed coffee as happy juice from personal experience. Do you have any information about caffeine and how it enhances a happy mood? I know a little about this because
Take it away.
I drink coffee and I have relatives in Finland.
Relatives in what?
In Finland, where they drink a lot of coffee, where they did a study that showed that as the number of cups of coffee per day went up, the suicide rate went down. Up to a certain point, when you hit 7, 8, 9, 10 cups of coffee a day, then it changed. From what I know is that, there are a lot of substances you have to worry about, and something like 85% of the country, maybe the world, is addicted to caffeine. I like coffee.
I like tea.
There you go. But caffeine doesn't seem to be problematic and may actually be helpful.
It may even be that caffeine is what we all take for our mild attention deficit disorders. The fact is, if you're not somebody who wants to take a true stimulant in pill form, and you have coffee and you use it throughout the day, you can actually concentrate even though you don't feel like it.
Yeah.
So that's
Part of the problem with coffee is caffeine withdrawal is also profound. You need that first cup of coffee in the morning, or else you're going to get a headache and feel kind of sluggish. So it may be that if anybody has weaned off caffeine for a while and then started back up, that first cup of coffee is amazing. But then it's really just getting back to baseline. If you're taking antidepressants and they work, are you taking those for the rest of your life? Shall I?
Okay.
Well, why not? You're one of the lucky ones if they work. I think of it like if you take a medicine for high blood pressure, if you take a thyroid replacement medicine, that if you're somebody who's taking a daily dose of antidepressant, it works for you, you're not suffering side effects from it, it's reasonable there, and there's no evidence that, long-term it's a problem. And now people have been on medicines like Prozac, which Prozac came out in 1988, so you have people on these drugs for decades. If you want to stop it for some reason or another, you have to be careful because there are these discontinuation symptoms.
Let me just say a little bit on the other side, which is that some of these antidepressants have major side effects that people really don't like. They get in the way of sexual pleasure, and they can also make you gain weight over time. And those are really kind of major side effects. So in fact, even though they can work very well over a lifetime, I tend to have a bias that if I can get people off them, I try.
Yeah, and I agree with that. I was talking about the singular case where, there are some people who take the drug, they don't have any side effects. Now, what we're both also aware of is that it changes over the lifestyle. So somebody who did fine with a SSRI in their 30s without sexual side effects, and they get into their 50s and 60s, then the sexual dysfunction can actually be worse. And so that, for example, might be a trigger to try to wean off it. And that person may, their situation has changed, their relationship, their biology has changed in many ways, and they may be able to do without the medicine or find other ways. Do you feel that all football players suffer from depression because of head trauma?
Wow.
No, not all, but there are terrible stories, suicides. I do think the problem with, again, there's all kinds of places where head trauma occurs. It's not the big concussions sometimes. It's the regular impacts. The other people who get into problems are soccer players, or the other, what the rest of the world calls football, with hitting the ball with your head. You see this problem with professional athletes. But obviously some escape. Again, it's not it doesn't have the same effect in everybody. You have some questions there you might want to?
I just saw this one, which says, are women really more prone to depression or just more likely to seek help? And I think that is the most important question, that society does give women greater permission to ask for help. But there are also some signs at these various points in a woman's life where she is more prone to depression. And when you think of all the hormonal changes and how important child rearing is and how important menopause is and getting the menses, and you realize that even in a fractal way, that every month when a woman gets her period, she gets a little bit depressed before her period comes, then she feels some relief when the period finally comes. So this is really the $64,000 question. And I find it a fascinating one, but I can't really answer.
Yeah, I think that this is the inherent problem in talking about large populations is that when you generalize, you get it wrong, because there are so many different. I do think, from experience and from reading the literature, that there is a difference. That there are differences in rates, and the biology is different, and the hormonal environment is different, and the social environment is quite different. I was also thinking, when you were talking before, about how women are encouraged to express, particularly sadness, but they're not encouraged to express anger.
Right.
And many women who are trying to be forceful in a business environment, in a work environment, find it very, very difficult, because if a man comes in and is forceful, that's considered a positive thing. If a woman comes in and is forceful, she's called names. And that's an enormous problem. One thing that I skipped over, and people are asking about, a couple of novel treatments, which you mentioned, and that was on one of my slides. Ketamine is a very interesting. People may be familiar with this. This is an anesthetic, which is also a hallucinogen. Often used in things like pediatric anesthesia. It's used in induction of anesthesia. In small doses, it's now been discovered that it has an enormously positive impact on mood. There's some evidence that you take somebody who's terribly, really very deeply depressed and very suicidal, and you give them a small infusion of this, and that feeling evaporates. The problem with it is it doesn't last. And so what we're looking for, and this new drug, esketamine, which has to be given under in a controlled situation, is a great advance. But it's ready for the evening news, not quite ready for prime time.
And it's extraordinarily expensive.
And very expensive, yeah. Along the lines, the other thing that's very interesting, I don't know if people read Michael Pollan's book. I forget what it's called, but it's about LSD, and that's research that began in the 50s and 60s. In fact, in my hometown of Newton, Timothy Leary was there with his group going on LSD trips and quote-unquote studying it. But there's really some serious research going on, and people report, this is not something that can be done in a professional setting. It's always done kind of under the table, but people report very interesting experiences. And this goes back to this interest in, which is obviously burgeoning as well, in mindfulness. This experience that people have take these hallucinogens, and they have an experience where suddenly they see the mind in a different way. And they don't, when they finish the experience, they don't look at their thoughts in the same way. They don't, in a way. One of my favorite expressions that somebody told me once, which I keep repeating, is don't believe everything you think, which is really the basis of CBT.
Right.
You have negative thoughts, don't believe everything you think.
Exactly.
It's also the basis of psychoanalysis. I mean, you're having these associations, and it goes back to your mother or your father or whatever it is. You've internalized these things. You have a story that you tell about your life, but it's just a story. You can change it. Don't believe everything you think. So there's something about these hallucinogens that seem to loosen up that.
It's true.
Here's a question that I like. The transition from college to full-time employment. can be challenging for individuals in their early 20s. Can you speak to any depression-related concerns or characteristics unique to this population?
Well, I am a child psychiatrist, and I have to say that between the time I grew up and the time I brought my children up and watched them grow up, the parenting norms changed enormously. So where I could disappear for 6 hours in the day and nobody thought anything of it by the time I was 8, we kept a rather close track of our children, and now people are keeping even closer track of their children. So children don't have the same ability to test out their autonomy in the world. And I think that then when they go from college, which is still a little bit protected, into a job and an apartment and a real life situation, they often feel woefully unprepared. And probably that does relate to the fact that they weren't allowed much freedom as kids, that they were always watched like hawks and were kind of under adult supervision. And if you're always under adult supervision, you don't quite feel that you could solve a problem on your own. So I think there has been an enormous change, and that now this transition is quite scary, and that we may have to have the pendulum swing back a little bit to give children just a little more time on their own to experiment with their judgment and learn some ability to make judgment.
There's a great book on this topic called The Coddling of the American Mind by Jonathan Haidt and Greg Lukianoff. It's really worth reading, and they talk about some of these issues. There's a political aspect to it, but there's also Jonathan Haidt is a social psychologist and talks about some of the changes in parenting. The term used to just be parenting. Then it was helicopter parenting, and now it's bulldozer parenting. So, kids, when I went off to college, and it's not like I wasn't that far away. I'm from New York. I came to Boston. Speaking of elephants, I went to Tufts, and I spoke to my parents once a week, maybe.
Right.
And now you can be on the phone texting after every class, between every class. Papers are edited. The whole thing. It's kind of constant management. One of the points that is made in this book is that we don't want to see our children as fragile. We want to see them as anti-fragile. The idea that they need experiences that mold them and teach them about what their own capacities are, so that they can enter the world and enjoy the pleasures of independence and creativity and the like. How are we doing on time? Maybe we can do one more question.
You've got a question?
One more question, okay.
Okay.
It'll take me 2 minutes to find the question, of course, and then we'll be out of time. That's another way to go.
This says, if depression and mental health disorders are so prevalent, why is access so limited and treatment not always covered by insurance? That seems like a fair question.
Well, this is a terrible problem. When people call me up and say for a referral, it's very difficult to find somebody, and it causes us to try to fall back on. The answer is it's expensive. It's expensive to sit and talk to somebody who's experienced. And if you want somebody to really think carefully with you about what you're struggling with and what the origins of the distress is, it takes more than an hour. It takes hours and hours to really understand what somebody's about, and that takes a lot of time, and time is expensive. There's no easy answer to this. One answer, though, is to go back to some of these basics, like paying attention to choices you make about lifestyle, So there was one question about sleep. Get a good night's sleep. Pay attention to the kinds of lifestyle choices that you're making that may, and these are very difficult things to do. But I mean, you were talking before about this, the flow. That the one thing that's great about the brain. There are many things that are great about the brain. It's my, as Woody Allen says, it was his second favorite organ. But people who are fans of Star Trek, space isn't the final frontier. The brain is. It's the most complicated machine on the planet. But it's enormously resilient. And what we learned in medical school is that you're born with your brain and then it just deteriorates. But what we know now is that there's this thing called neuroplasticity. As you're listening to me, as I'm talking to you, our brains are changing. It's not just the medication that changes the brain. Experience changes the brain. Practicing the piano changes the brain. Meditating changes the brain.
And using real relationships.
Yes.
When you talk to people in your life about your troubles and you let them try to be helpful, it's amazingly effective. It's not that only therapists can make depression better. Depression is often time limited, and you can use the network you've got. And every hospital in the city has some free care.
Yes.
So if you need to get psychiatric help because it's not enough to talk to your best friend, then every clinic in the city does give some free care.
And primary care doctors are highly trained in behavioral health. They know that health, first and foremost, is about behavior and lifestyle. And so they're often an excellent resource for leading you to people who can help you.
Exactly.
So I think we're out of time, but thank you very much, everybody.
Thank you. Thank you so much.